Now we will continue with the previous lecture with the name of examples of individual interventions. An intervention delivered by smartphone could be a convenient, potentially cost-effective, and wide-reaching weight management strategy. A smartphone app intervention, My Meal Made, was developed using an evidence-based behavioral approach. The app incorporated goal setting, self-monitoring of diet and activity, and feedback via weekly text messages. The app was tested in a sample of 128 overweight volunteers, randomized to receive a weight management intervention delivered either by smartphone app, website, or paper diary. Mean weight change at 6 months was 4.6 kg. In the smartphone app group, this was higher than the other groups, showing the potential for this type of individualized intervention. For Life is a social marketing campaign started in the UK in 2009, supports the overall healthy weight, healthy life strategy aiming to reduce obesity rates. Change for Life initially focused on families with children aged 5 to 11 years who were at greater risk of becoming overweight or obese. The element of this campaign included targeting individuals most in need of help. It is adults whose attitudes and behaviors placed their children most at risk of excess weight gain, providing insight into why those individuals behaved in this way, creating a communications campaign to change attitudes, providing products such as handbooks, questionnaires, wall charts, web contents that people could use to help them change, signposting people to services such as breastfeeding cafes, accompanied walks, free swimming, and cookery classes, bringing together a range of organizations, including the commercial sector, who used their influence to change behavior. The idea was that the program should be more than just provision of information, which we know is not particularly effective. Evaluation at year first found that brand awareness was high and positive. Mothers claimed to have made changes to their children's behavior as a result. Actual impact on dietary behaviors was not assessed directly. Complex interventions designed for the individual will require input from a range of disciplines, including epidemiology, psychology, public health, environmental planners. Intervention design should include understanding of how the intervention will start in behavior change through conscious or unconscious actions. Tailoring of the initiative to the individual is required and may depend on a range of social, environmental, and lifestyle factors. Now we should take a look on omics approach. What is the omics approach? The majority of dietary advice is based on population guidelines using a one-size-fits-all approach. Some recommended nutrient intakes and other nutritional advices are stratified based on age, gender, pregnancy status, or BMI, but only a small proportion of advice is personalized through the use of clinical measures. Since the sequencing of the human genome, the recent growth in the knowledge of genes, nutrient interaction has the potential to increase the effectiveness and availability of personalized nutrition. The relatively new and expanding field of nutritional genomics include nutrigenomics, which shows how food and nutrients affect gene expression. Not only how food affects the genome, but also how it affects the expression of messenger RNA, proteins, and metabolites. Also included in the field of nutritional genomics is nutrigenetics, which explores how gene variation, single nucleotide polymorphism, can affect a body's response to diet and nutrients, thereby potentially resulting in an increased or decreased disease risk compared to people who do not have the gene variation. Single nucleotide polymorphisms can result in altered end products of gene expression. Proteins such as enzymes with altered structure and function. Personalized nutrition could be based on either genotype, which is the set of genes that a person carries, or phenotype, which is the individual's characteristics linked to their genotype and environment. Let's have a look of personalized nutrition. There are some examples of nutrigenetics, effects on human health. A classical gene mutation, such as phenylketonuria, has been known for many years. People with mutations in the enzyme phenylalanine hydroxylase cannot metabolize foods containing the amino acid phenylalanine and must alter their diet to minimize consumption. With modern genomic data, gene mutations with less severe effects are being explored to determine whether dietary practices can be more closely personalized to individual genetic profiles. Riboflavin supplements can reduce blood pressure in hypertensive individuals with the methyl tetrahydrofolate reductase 677PT genotype. Folic acid supplementation may be beneficial for the carriers of C677T and A1298C polymorphism in the anti-HFR gene because these are associated with impaired folate metabolism and cardiovascular disease risk. Let's take an example which is hemochromatosis. Hemochromatosis is an autosomal recessive disease that is characterized by progressive iron overload. Is an example of how a single gene variation can affect an individual's response to diet. Two common mutations of the HFE gene have been linked to hereditary hemochromatosis, C2A2Y and H638. Postmenopausal women eating a diet rich in heme iron and who carried two C2A2Y mutations had the highest serum ferritin concentration compared with those who carry other combinations. C2A2Y homozygote individuals are advised to eat less meat, particularly beef and lamb, which contain the highest levels of the easily absorbed heme iron. Progressive iron overload will eventually lead to organ failure, diabetes, and early death. It is set within the journal population-based dietary advices, encourages the intake of iron to prevent the deficiency. Postmenopausal women carrying only one copy of the C to A to Y mutation may have higher than average iron absorption and could be advised to reduce their iron intake. Higher levels of iron storage within the normal range may predispose individuals to many chronic diseases, including heart diseases, diabetes, and some cancers. Differences in an individual's phenotype rather than their genotype may be used for providing nutritional advice. An example is the individual variation in caffeine metabolism and its effect on fetal growth restriction during pregnancy. The journal advice to pregnant women is to reduce their caffeine consumption during pregnancy because caffeine consumption has been associated with increased risk of fetal growth restriction. Measuring the half-life of caffeine in saliva shows that women with a faster compared with a slower caffeine clearance would be at greater risk of giving birth to babies whose growth is restricted. The amount of the caffeine available to both the mother and the fetus depends on the enzyme cytochrome P450-1A2, the principal enzyme involved in caffeine metabolism that is present in that is basically absent in the placenta and the fetus. Genetic differences are to be involved. Pregnant women would not only need to undergo caffeine metabolism test rather than a genetic test. Environmental factors such as nicotine intake also influence caffeine metabolism. Test results providing evidence of faster metabolism of caffeine are likely to have a greater influence on pregnancy. To reduce their caffeine intake than the general advice given to the women. Another example of nutrigenomics is apolipoprotein E. Nutrigenomic based personalized nutrition has the potential to be more effective at preventing polygenic NCDs such as CVD, cancer, and obesity than population based guidelines. It has been shown that individuals with the E4 genotype of apolipoprotein E, which has been associated with a greater risk of heart disease than the wild type genotype, has a much larger and beneficial response to low fat diets in relation to circulating lipids implicated in the development of heart disease. What you know about the genetic trailing of diet? Future researches may help to classify individuals into those that are likely to respond well to certain diets. Tailored diets to genes involved in metabolism can aid weight loss in obese individuals, though larger randomized trials on this are required. A large European trial, Food for Me, which is the name of the trial, did not find that knowledge of phenotype or genotype affected dietary behaviors. Incorporating individuals' food preferences is likely to improve acceptance of a new personalized diet. Individuals could also be tested for genetic differences in taste. Genetic differences in sensitivity to bitter taste and to sweetness have been found. Advice on food preparation to improve the palatability of healthy foods perceived as bitter could be provided within tailored diets. There are common TAS2R38 haplotypes that influence the ability to taste phenylthiocarbamide, propylthiouracil, as well as thiocyanate found in the brassica vegetables such as broccoli and Brussels sprouts. Higher intakes of these vegetables have also been linked to decreased cancer risk, and although sensitivity to bitter taste may reduce the intake of these. Non-communicable diseases are associated with a variety of genes involving complex interactions between genes and the environment. The use of nutritional genomics and its solutions are likely to be complex and difficult to apply. A number of factors need to be in place or considered before the broad application of personalized nutrition to the population at large. These factors include regulations and ethical considerations. Regulations should cover nutrigenomic testing, providers and their claims, and new functional food products and related claims, as well as the privacy and storage of genetic data. Social and ethical considerations include unequal access to personalized nutrition, possible pressure on people to use the service, and the psychological cost of genetic testing. Some countries already have more developed strategies in in relation to some of these issues than other countries. In 2004, the European Scientific Community established the Nutrigenomics Organization to pull together multidisciplinary scientific knowledge to develop and validate research tools and, among other things, to educate healthcare practitioners. Similar organizations around the world have also been established. It may be some years before the evidence base is sufficiently robust to provide nutrigenomic-based personalized nutrition in the marketplace to the population at large. Current promotion on a wide scale is likely to be premature and open to exploitation by private companies, directly targeting the general public who could be misled. Private companies abandoned personalized nutrition marketing strategies in the UK after organized customers marketed in the USA through health practitioners as well as directly to consumer outline. New functional foods are also marketed in the USA. Functional foods often incorporated bioactive compounds. These compounds could interact with genetic polymorphism, and individual's genotype may prevent them deriving significant benefit from an increased intake of such foods, and some who may be disadvantaged. Some productive consumers may be willing to pay directly for personalized nutrition services and products, whether or not claims are endorsed or regulated by officials. Clear regulations is needed, not only to protect the consumers, but also promote the trust in personalized nutrition services and products. Because of its individualism, personalized nutrition is most likely to be taken up privately, and inequality of access to the services and product is likely to result. Some polymorphisms may be common enough for nutritional advice to be provided at a stratified level and for functional food product to be mass produced. Equitable access to these may still be an issue. Strategies to encourage and enable poorer and less proactive individuals to access personalized nutrition services and products may be needed. If there are clear benefits for the individual and society in using these services. Once the evidence base and regulations are in place, the uptake of personalized nutrition in the wider community is likely to depend on an individual's willingness to be genetically tested. Success will depend on their motivation to adhere to nutritional advice based on their genetic test result. Sufficient self-efficacy or social support will be needed to maintain adherence to the advice. Diets tailored to genetic taste preferences may also help. A large proportion of individuals from many countries are willing to be genetically tested for the prevention of diseases, round about 48 to 85%. This is likely to be considerably lower when cost to the individual is taken into account. Out of the 6 European countries, the UK was most willing to be genetically tested for personalized nutrition. Such individuals may also be more motivated to comply with nutritional advice based on their genetic test results. The diet can reduce risk, and their genetic predisposition is not seen as fatalistic. Although the uptake of personalized nutrition may be more likely for proactive individuals with heightened perceived susceptibility to disease, they may not represent a large proportion of the population to produce a large overall reduction in disease risk. Even a 1% reduction in relevant risk of cardiovascular disease in England and Wales. Privacy was found to be a particular concern relating to genetic testing in the US, surrounding potential misuse of genetic information that may impact the cost and provision of insurance policies and may impact acquisitions of jobs. Some individuals may react in a fatalist manner to results and not alter their eating habits. Genetic results may cause distress and anxiety if pre and post test counseling are not provided, and if the advised increased risk cannot be effectively reduced. Nutrigenomics testing may create large numbers of worried birds, and its psychological effects may be burdensome. The resulting stress may even promote the diseases. Evidence-based education of health practitioners, dietitians, and nutritionists in this new area of health is needed for it to be successful on a wide scale. Communication to the general population should help to develop confidence in personalized nutrition without confusing and weakening current population public health messages, which will remain important. In the past, media reporting of conflicting associations between nutrition and disease risk from individuals has confused or disillusions a large portions of the general public who now mistrust nutritional information. Information can be delivered more directly to the general public through face-to-face contact with healthcare professionals or via the internet by private companies supplying direct-to-consumer testing. Face-to-face counseling, pre- and post-testing reduces the financial viability compared with direct-to-consumer delivery. Costs are minimized in the latter by utilizing self-administered genetic swabs, resulting from which can be interpreted and then feed back to the individual by mail, electronically or by telephones. Future research could compare the effectiveness of different methods of delivery on dietary change and disease prevention. Consumers may be suspicious about the commercial interest of private companies and believe that they may be motivated more by financial gain than by health promotion. The European Nutrigenomics Organization has started to address this issue by providing the training courses. Also, the European Food for Me project, which have the website www.foodforme.org, has researched best practice communication strategies. Nutritional genomics is a promising field of research that has the potential to reduce the non-communicable diseases through the personalized nutrition advice based on knowledge of genetic environment interactions. It is too early to evaluate its effectiveness. Let's have a look on effective policies and effective intervention. Nutrition interventions are vital for addressing nutritional challenges at a population and individual level. Interventions focus on high-risk groups and major areas of concern and include health promotion and disease prevention. One of the WHO core functions is the development of global guidelines for nutrition interventions. This is a rigorous process which ensures guidelines are based on scientific evidence to ensure the transparency of development and best practices. The WHO has created the WHO Handbook for Guidelines Development, which considers the external and internal stakeholders, regular review throughout the planning stage, and a public call for input. A figure you can see here on your desktop. This is the WHO guidelines development process on nutrition actions. The global guidelines produced by the WHO to inform the guidance on how local policy can improve nutritional status throughout the life cycle, provide a framework for country-specific policies to be developed and implemented. This provides a suite of nutrition actions alongside the latest recommendations, scientific evidence, and expert commentary. ELENA aims to support countries in implementing nutrition interventions, guide local policy development, and inform program design. When creating guidelines, the WHO adopts the life cycle approach. This recognizes the unique nutritional needs of individuals at different varying stages, from conception to infancy, childhood to adulthood, and through to old age. Each stage has different nutrition requirements. To address these stages, In particular, the key development stages, the WHO has created over 150 nutrition actions, divided into key life stages of evidence-based guidelines to inform local nutrition interventions. How we implement successful intervention. A successful intervention must address the multiple burden of malnutrition, and caution must be taken not to replace one burden with another. An effective intervention should be multi-level, reaching vulnerable population by providing adequate food environment, education, promotion, and social welfare support throughout all stages of planning, implementation, and evaluation. There must be accountability across all levels. There are some considerations need to be made, which includes risk groups must be identified. Who is at risk? Where do they live? What are the determinants of the risk? How many people are affected? And what are the causes? The correct type of intervention must be identified to promote health and prevent the diseases. Which intervention will best affect change and reach the target population? Second consideration is about cost benefit analysis. Cost benefit analysis must be undertaken through systematic analysis of the strengths and weaknesses of the intervention, ensuring that the benefit of any given intervention is greater than the cost. Economic modeling should also be used to inform planning decisions. Key stakeholders must be identified during the planning process. A good intervention should be multifactorial and engage multi-level stakeholders to ensure it reaches vulnerable population. That is farmers, distributors, farmers, health practitioners, and the local community through education and promotion. Fourth consideration is the community engagement. Community engagement is basically a key on a local level. Cultural sensitivities must be taken into considerations, and interventions must align with cultural values. And the fifth consideration is implementation. Once implemented, ongoing promotion and communication are key to maximize engagement. When setting interventions and programs, evaluation methods must be built in using systematic processes to monitor efficacy. There must be scope to modify the intervention where necessary. Seventh consideration is programs should be effective in the long term and must not cause harm. And eighth consideration is about appropriate successful intervention. Where appropriate successful intervention can be translated into national policy and legislation. Of successful intervention with multifactorial stakeholder collaboration is Healthy Growth Project. Healthy Growth Project is a collaborative project coordinated by the WHO to promote healthy growth and reduce childhood stunting. Stunting growth and development causes a child to be short for their age and have impaired cognitive, motor, and language development. This can have a large impact on the community, as children are at greater risk of obesity and disease and are less able to contribute to the economy. Stunting can be caused by the poor maternal nutrition, poor feeding practices, inadequate sanitation, and water supply or food insecurity. The project's main aim is to support countries to implement stunting reduction targets to contribute to the achievement of the WHO stunting reduction targets. It aims to develop tools and framework to make stunting the primary measures or undernutrition rather than weight, to raise the awareness of the relationship between stunting and non-communicable diseases, and to increase understanding of the link with obesity in later life. Because the etiology of stunting is multifactorial, the project promotes cross-sectorial approaches, engaging the stakeholders at a national, subnational, and grassroots level, encouraging accountability at all intervention stages. The project calls for capacity building and political will through infrastructure and policy implementation at the national level. The foundation of the project focuses on the importance of the caregivers' education and community engagement, as the local community has been identified as key to healthy child development. The project promotes the local and national collaboration, using combined multifactorial actions to intervene at multiple levels to improve the maternal health, improve feeding, promote healthy diets, strengthening the food system, and improve water supplies, sanitation, and hygiene. To ensure the efficacy, the project recommended setting goals and targets to allow for performance tracking. Regular monitoring is encouraged and modifications should be made accordingly. Stakeholders should be regularly updated throughout the program to ensure collaboration continues. Global policy documents indicate priorities. Decisions must be made nationally, giving consideration of the epidemiological patterns, the country's political and administrative practices, as well as the existing capacities and the presence and commitment of national actors and development partners. Individual countries must be responsible for their own target and priority setting. Nutrition plans should consider direct interventions, usually delivered through the health sector, or nutrition sensitive interventions delivered through the agriculture and social protection. Example of the multi-sectoral plan to improve the diet is the Recipe for a Healthier Diet, an action plan developed by the Norwegian government with a vision to improve the public health through a healthy diet. The plan aims to help the people choose healthy diets, facilitate good meals in kindergartens, schools, and among the elderly, and increase knowledge about food, diet, and nutrition. The plan was a collaboration across 12 ministries: labor, social inclusion, children and equality, finances, health and human services, local government, and regional development, cultural affairs, agriculture and food, environment, trade and industry, fisheries and coastal affairs, education and research, foreign affairs. Included in the plan were 73 measures across 10 key areas, including communicating about food and diet, encouraging the production of healthy foods and meals, promoting the consumption of fruit and vegetables and fish, promoting the good nutrition since birth, providing healthy meals in schools and the workplaces, improving nutrition through health and social services, strengthening research and monitoring. The document also gave consideration to the administrative and financial implications as well as follow up the evaluation to continue to monitor dietary changes. The efficacy if the plan was evaluated by the WHO and a comprehensive report published by WHO. The journal finding of this plan published by the WHO include the nutrition policy had increased knowledge of nutrition and health in the population. Dietary patterns had shifted with the reduction in the fat intake and increased fruit and vegetables intake. Authorities viewed the plan as a supportive tool for initiating and implementing nutrition-related activities. Aggressive marketing campaigns of foods high in fat, salt and sugar are negatively impacting the diets of the younger generation. While the report acknowledges room for improvement in some areas, it highlights that plans should be seen as an example of good practice in the application of the WHO Health 2020 policy framework. In 2009 to 2010, the WHO conducted a global nutrition policy review, to which 119 member states responded. Most countries indicated that they had established policies and programs to tackle undernutrition, obesity, and diet-related non-communicable diseases, infant and young child feeding, and vitamin and mineral malnutrition. The review emphasized that policies were not officially adopted, were variable quality, and did not have adequate budgets and resources. Policies were lacking operational plans and programs of work, were missing clear goals, targets, timelines, or deliverable, did not specify roles and responsibilities, and did not envisage an evaluation. Secondly, the report identified challenges in governance. Many countries did not have intersectoral coordination mechanisms placed at a high level, such as a Prime Minister's or President's office or a planning commission. Third, countries were not implementing a comprehensive package of interventions at different stages of the life course, and not eligible beneficiaries were reached. The quality of implementation was variable. The human and financial resources were inadequate. The nutrition surveillance system in place were insufficient in relation to the list of indicators, the level of disaggregation, and the frequency of reporting. To help improve the nutrition policy development, the WHO has developed tools that may help formulating policies, such as landscape analysis of stakeholders' commitment and capacity to scale up evidence-informed interventions, or the One Health tool to facilitate strategic planning through cost-effective analysis. The WHO has also established GINA, a global database on the implementation of nutrition actions, which includes policy documents and implemented programs from over 170 countries so that good practices can be better identified. On 1 April 2016, UNGA adopted resolution entitled United Nations Decade of Action on Nutrition. The UN has declared decades to call the international attention on major development topics since the 1970s, but only two are specifically named decades of action: water and road safety, to highlight the determination to translate into concrete action the political commitment made. With the decade of action on nutrition, there is an expectation that governments and other actors publicly announce which recommendations of the ICN2 they are going to implement and when, so that public accountability mechanisms could be built. This is an unprecedented opportunity for the public health nutrition. the directions for the change are clear and broadly expected. There is an understanding of the broad range of sectors and actors needed. High-level commitments have been made and accountability mechanisms are in place. Public health leadership is necessary to ensure that serious change happens for the sake of people and the planet's health. Nutrition strategies designed to deliver improved dietary behaviors for the community can be created and delivered at a number of levels. At one end of the spectrum, legislation eliminating choices is possible. The emerging field of nutritional genomics will allow tailoring of individuals' dietary interventions to focus on those who are likely to benefit the most from particular recommendations. Evaluation of different approaches is needed to determine effectiveness and ensure that health inequalities are not widened.